Good afternoon, and welcome to today's program titled Childhood Trauma and Subsequent Addiction. I'm Julia Brown, Associate Editor of Addiction Professional. Today's program is sponsored by Sierra Tucson. Thank you to our sponsor and to those of you in our audience for giving us your time and attention today. Before we get started, we have just a few housekeeping details. Each window on your screen can be moved by clicking and dragging, or enlarged and minimized by clicking the icons in the top right corner of each window. Please use the Q&A area to the right of the slides to submit a question at any time. If you cannot see this area, simply click the red Q&A button. To download a copy of today's presentation, please click the link in the Resources area in the lower left of your screen. If you have any technical issues during the program, please click the yellow Help button to troubleshoot the issue. A special note about CE credit. To receive credit for today's program, you must click the green CE certificate widget at the conclusion of the program and complete the evaluation form. You must watch today's webinar for at least 50 minutes in order to obtain a certificate. If you are watching today's program in a group, please download the group submission form located in today's resources list and follow those instructions. If you have any issues with this process, please do not reach out to today's sponsor, as they will not be able to assist you in receiving a certificate. Please also note that CE credit is not available for the archived webinar. It is only available for the live event. Finally, you can also tweet during today's webinar via the Twitter widget by clicking on the blue Twitter icon at the bottom of your screen. Simply click the Post and Authorize buttons to log into your Twitter account and begin sharing automatically at the event hashtag #APLiveWebinar. At this time, it is my pleasure to introduce our speaker, Dr. Michael Genovese. Dr. Genovese is the Chief Medical Officer of Sierra Tucson, as well as an Assistant Clinical Professor of Medicine at the University of Arizona, a diplomat of the American Board of Psychiatry and Neurology, and a member of the American Psychiatric Association and the American Academy of Addiction Psychiatry. Before joining Sierra Tucson, Dr. Genovese co-founded Long Island Mind and Body, a highly successful medical practice that brought state-of-the-art integrative treatments to a growing patient base in metropolitan New York. While establishing LIM, he also practiced as an attending physician at nearby Winthrop University Hospital. He was a fellow at the New York University North Shore University Hospital Child and Adolescent Psychiatry Program, and he completed his residency training at the University of Connecticut School of Medicine. Thank you, Michael, for taking the time to speak with us today. And with that, the audience is yours.
Thanks, Julia. And thanks, everybody. Thanks for joining. This is a topic about which I'm really excited. And I want to tell you at the beginning that this is going to be a review for a lot of you, the information that we're going to go through. But I want you to keep in mind that it's not a review for our patients. And my big thing is communication to patients. What we think of when we talk about patients with trauma and with addiction is they have a lot of things in common, one of which is shame. And they need us to help with that, and they need us to render hope. So what I'm hoping today is a hopeful message about our understanding of how early childhood events can lead to subsequent addiction, that we understand it better, and that we also can do things to help, that we can impart hope because we're better at treating than we used to be. So with that in mind, let's talk about this. Early in my medical training, and I think a lot of people had this experience, we'd be treating patients that presented primarily for addiction. And at some point during their treatment, they would disclose an early childhood trauma. And I remember a lot of us thinking, geez, I wonder if there's something there. And now there's substantial epidemiologic data that indicates that trauma that's experienced early in life in fact predisposes one to addiction in life by a number of mechanisms that we're going to discuss today. I think at this point that there's enough data, there's enough epidemiologic data, there's enough bench research data that we can say pretty unequivocally that early developmental trauma and exposure to stressors produce a number of neurobiological abnormalities, including changes in neural circuit function, which can manifest in substance abuse or dependence. Trauma in children, physical, sexual, emotional, alters the child's stress mechanisms, and resultantly, the child's more likely to be reactive to stress throughout their adult life, and it renders them more vulnerable to maladaptive substance abuse and dependence. As one develops, the organization and the functional capacity of the brain depends on it's an extraordinary sequence of developmental and environmental experiences that influence the expression of the genome. And the expression of the genome is another thing that I'm really excited about. The study of this process called epigenetics, which many of you are probably familiar with already, it's one of the most rapidly growing areas of scientific research, and it's something that we're going to touch on here during this presentation. Now, this sequence of events in development that I was referencing, unfortunately, it's vulnerable to dysregulation in the face of extreme, repetitive, or abnormal patterns of stress during critical periods of brain development, which can impair the activity of major neuroregulatory systems with profound and lasting neurologic consequences. The damaging effects of these adverse childhood events, well, they're nonspecific. They affect various areas of the brain and neurotransmitter systems. However, dopamine and dopaminergic neurotransmission is a common factor in many of these instances, and it's a common factor in many disease states. And dopamine plays a major role in our fight or flight or risk-reward stress response system. So we know that the dopamine system is implicated in lots of different states. We know that if we're dealing with patients with addictions, with mood disorders, with eating disorders, with trauma, even patients with pain, dopamine is often implicated. And so we're going to talk about some of the ways the dopamine system works within the context of these disorders. So let's go on to the next slide. So as our largely dopamine-mediated risk-reward system is so pervasive and affects so many parts of the brain and behaviors, our patients experience a broad range of symptoms, and these symptoms can fluctuate pretty rapidly and pretty frequently during the course of their treatment. And there we can observe all sorts of different complaints of pain, the cravings, moods ebb and flow. And as healthcare professionals, it's incumbent upon us to treat the whole patient. So here at Tucson, we're a teaching program, and we have medical students that rotate with us, and they get sick of hearing me say that we have to treat the entire patient. We treat the individual patient and the entire patient. But what I'm trying to convey to them is a patient comes in and they're presenting, for the first time, and they're here for trauma. Don't ignore the fact that they're coming to you on another day with complaints of pain, or that you have to pay attention to mood symptoms. We have to adapt at each time while we deal with the entire patient. We're treating people. We're not treating a history, and we're not treating a list of pathologies. And I think that the optimal management of patients, such as these multi-layered patients, and especially patients who have a history of trauma and substance dependence, requires a comprehensive, integrative approach. And so I talk about integrative medicine, and I go around, and we can move on to the next slide. What I found is, going around the country, you can You can talk to 10 different people that purport to be integrative psychiatrists, and you can get 10 different explanations of what integrative psychiatry is. So I figure since we're going to be talking about that, I should define what I think integrative medicine is all about. So first off, the first pillar of integrative medicine is all about the relationship between the patient and the practitioner. I mean, that's the most important thing. It's more important than any pill I can prescribe. It's more important than any test that I'm going to run. It's a different sort of relationship than the sort of traditional allopathic relationship that, for example, my dad had with his patients. My dad was a cardiologist in the 70s, and that was more of a sort of top-down, authoritarian, here's what you're going to do kind of relationship. When I'm with patients, I have to meet them where they're at. By the time a patient gets to residential treatment, they've probably failed 2 or 3 other courses of treatment that they've tried. These patients with a long history of trauma and addiction, if I prescribe them another course of treatment with which they can't comply, neither of us are going to get anywhere. So if a patient comes in and says, listen, Mike, I've been on an SSRI 5 times before. I don't want to be on another one. My job is not to convince them that they do. My job is to team up with them and figure out what will be helpful. And it's upon both of us to be establishing this care plan. And one of the most important parts of this one that I tell my patients is I cannot be working harder than you. We have to work at this together. The second pillar that I talk to people is focusing on, like I was telling you about with the medical students, focusing on the whole person and the individual person. You know, if I walk into Morning Report and there are 4 people and they all have the same Axis 1 diagnosis, I better see 4 different treatment plans in the chart, because there's no cookie-cutter way to treating disease states like addiction with a history of trauma. What might work for one person might not work at all for the next person, and we need a different combination for all of these people to optimize their treatment. Integrative medicine is informed by evidence at its best. I love randomized, placebo-controlled, double-blind trials. I love having those studies that I can show the patient because it confers some confidence in the modalities that we've chosen. It also gives some confidence to the referring professional that gave them to us. I can say, here's what we're going to choose. Here's why we're going to use it. And I have a lot of respect for the body of knowledge that practitioners accumulate and their experience. And I think that it's important to integrate that experience with science that's founded in these studies. So I think that that's really important. The fourth pillar, we're going to talk a little bit about all of the therapeutic approaches that are used, that could be used in any one patient, really. And one of the great things about being an integrative psychiatrist is I don't have to be an expert in everything. I have to know enough to know who to ask the right questions. I have to know who to consult. And I have to be able to synthesize the information for the benefit of the patient and the patient's family. But the great thing is being able to reach out to a really smart therapist or a really smart naturopathic physician or a really smart acupuncturist who can be helpful in the context of this treatment. And then the fifth pillar is addressing all aspects of the patient's life, physical, emotional, spiritual. And I think implicit in that is cultural. You know, we treat people from all over the world. And I can't just superimpose my cultural views on that patient and expect to really render the best care that we can. When you think about the things that we're dealing with in psychiatry, and we're talking about behavior and choices and even dealing with medicine and doctors and parenting issues and work issues and sexual health issues and end-of-life issues, if I don't take into account the cultural lens through which my patient is viewing life, I'm going to miss the boat half the time, at least, and I'm not going to be able to help them as much as I can. So that's basically what integrative medicine's about, and it's also about taking the best of what we've always been doing traditionally for 2,000 years, and let's integrate that with the best science that's around now. So, for one patient, we can use something like acupuncture, and we can also use something like transcranial magnetic stimulation, something on the cutting edge, and all of it is okay, as long as it's for the benefit of the patient. Okay, so now I put up a slide here looking at, I had mentioned that dopamine is active in a lot of different ways, and dopamine gets dysregulated at an early age in the context of trauma. And the reason I put these up here is in the past, I think we had thought of trauma as addiction as sort of separate and distinct entities, but there's a lot in common from a pathophysiologic perspective. Dopamine is implicated in addiction and also in stress and trauma. And we're seeing here, for the people that are interested in this sort of thing, some of the different pathways. We see the mesolimbic pathway, which is primarily implicated in the regulation of our risk-reward system, and also our mesocortical dopamine pathway, which plays an essential role in cognitive control, motivation, and emotional response. Now, early childhood trauma has been shown to affect the development of both of these symptoms. And think of the patients that you've treated that have had trauma, that are now experiencing addiction, and think about how their fight or flight mechanism is dysregulated, or what their motivation is like, and what their emotional response to triggers are. And it really starts to make sense from a neurobiologic perspective. As we come to understand that trauma alters stress mechanisms, we see that the child often becomes more reactive to stress throughout their life. Substance abuse or dependence can be related to the stress response in an attempt to self-soothe, and in other ways. Childhood emotional loss and trauma, then, if we look at it, it provides an experiential, a psycho-emotional, and a physiological template for addiction subsequently. Now, stress affects the whole body. We know that there are areas in the brain, specifically in the brainstem, that regulate autonomic function. Autonomic functions such as heart rate, respiration, and blood pressure. We also know that there's the hypothalamic pituitary adrenal axis that's involved in the endocrine response to stress. Now, by affecting the normal development of these systems, and I put normal in, I think of normal in quotations because, what's normal? But when you think of sort of what we would think of as a normal, devoid of extreme trauma and stress, normal development in these systems, early trauma has consequences for how human beings respond to stress throughout their lives. And stress has a lot to do with addiction. And when I talk to patients, I like to tell them about stress itself because a lot of times we throw that word around and we have different definitions for it. We don't really tell patients what we mean by it. But stress is a physiological response mounted by an organism when it is confronted with excessive demands on its coping mechanisms, whether biological or physiological. And then we attempt to maintain an internal biological and chemical stability, which we call homeostasis, in the face of this stress and of these excessive demands. The physiological stress response, which kept us alive, right, which is what facilitated the survival of our species. If there was a tiger, 3,000 years ago, well, we needed to go into fight or flight. We needed to mount this stress response so that we can get away and we could live. This stress response involves nervous discharges throughout the body and the release of a cascade of a whole bunch of hormones that they affect pretty much every organ: the heart, the lungs, the muscle, and of course also emotional centers of the brain. So trauma and addiction, which dysregulates this system, they carry clear implications not only for the psychiatric health of our patients, but also for their general health, for their cardiovascular, renal, endocrine, and every other area of their health. So here's the good news. and this was what I was alluding to before, we're learning better ways to treat not only the symptoms that result from the dysregulation of development, but we're also learning to address the underlying etiology, the genetic vulnerability and the protective capacity of our DNA through active modulation of our genetic expression. And I'm going to show you a slide in a little bit that talks more about that, but that's one of the hopeful messages, is that because we've been talking about it, because we've been researching it, we understand it better. And because we understand it better, we can address it better. And because we can address it better, we can confer hope to the patients who are looking to us for help. So there's a couple more slides here for people who are interested in the pathways that are involved in this. I find that sometimes it's interesting to look at what we consider to be, if we can advance to the next slide, the reward pathway. Yeah, there we go. And how this sort of correlates with trauma and addiction. And on the left hand of your slide, you'll see what we would call a normal reward pathway, right? So you'll see the ventral tegmental area, and so when something good happens, right? So if you eat a piece of chocolate cake, for example, the ventral tegmental area sends a bunch of dopamine to the nucleus accumbens. And that gets coded as something good, something that I enjoy, something that I'd like to do again. And this is part of the reward pathway that kept us alive. So, you know, interpersonal intimacy and eating good food and those sorts of things. These are things that get coded as something that we should do again and keep doing because it helps us to stay alive. And what happens after that is the nucleus accumbens, well, it does a couple things. It sends a feedback loop in the form of enkephalins to the ventral tegmental area. And so there's a feedback loop that starts there. And it also sends some signals up to the prefrontal cortex in the form of serotonin. And so you can see how mood becomes implicated with this. Now on the right-hand side, you'll see how different substances of abuse affect the reward pathway. And you can see how, listen, people that have been working in this field know, we've seen patients that display this. For a lot of people, OxyContin is a lot more powerful than a piece of chocolate cake. And this reward pathway that was supposed to help us stay alive has been hijacked in a lot of our patients. Now, when we think about the patients who are now manifesting their addiction, and we think about earlier in life with them, early stress, early trauma establishes a lower set point for a child's internal stress system. So such a person becomes stressed more easily than normal throughout their life. So if we compare a person whose baseline arousal is normal with another whose baseline state of arousal is at a higher level, it's interesting because, for example, you could give both of them alcohol and both could experience the same intoxicating effect. But the person who has this higher level of physiological arousal will have the added effect of feeling pleasure from the relief of that stress. So it's similar to the analogy I sometimes give is, you know, if you give someone, two people, a drink of a nice cool drink. If one of those people has been out in the hot, in the desert, and their throat is parched, they both will enjoy the taste of the drink, but that person who's got that dry, parched throat, the pleasure is heightened by the relief of the thirst, much in the way the alcohol relieves, at least in their perception, the stress. Okay, so we'll advance to the next slide here. Now, we frequently, and if you've attended conferences and you've listened to anything about addiction, you'll see how people often when discussing developmental changes associated with trauma and addiction, reference different anatomic and physiological changes in specific parts of the brain. People talk about hippocampal volume being different in patients with trauma or with addictions, or the activity in the prefrontal cortex and differences in metabolism. And for me, the question is always, well, okay, I get that. Why? Why is it that those sort of things happen? And it's in large part our understanding of development and the connections that are occurring. The part of our development is the connections between neurons in the brain that occur experientially. So we should talk a little bit about the development of the human brain and how this occurs and why some of these anatomic changes that we're discussing and that we understand that they happen. Let's take a look at why they happen. Okay, so if we advance to the next slide here, we can see that at different ages, the brain looks different. There are, if you look at MRI scans of a person who's a week old versus a person who's 10 years old, you don't have to be trained in medicine to see that there are differences there. But what's the real significance of some of these differences? Certainly there's growth, certainly there's size, certainly there's volume, and there's all sorts of differences that we could point out. But where the real import is in what connections are being established, at what age, and in what context. And this is the trajectory of the people that we're seeing. So if I can advance us here to the next slide, I'd like us to take a look at really what's happening more on a microscopic level. At a very young age, our neurons express dendrites and form synaptic connections. So as a matter of fact, around the ages of 5, 7 years old, we have more connections than at any other point in our life. We have more of these synaptic connections. That doesn't mean that we're smarter at 5 to 7. It just means that we have more connections at that point. And what's happening is every time we have an experience, every time we learn something, a connection is made. Now, you can't continuously have these connections made, it just becomes overwhelming, and it would become too much information. It would be too much for us to handle. So at a certain point, the brain starts to undergo a process called pruning, whereby some of these connections that are formed are removed. And if you look, so at the left-hand side of the screen, what's represented is the connections that are at a child's birth. Very, very few. And all the way on the right-hand side, you'll see at 15, there are many more than at birth, but far less than at 7. And what's happened between the years of 7 and 15 is a lot of those connections have been pruned away. And the question for me has always been, well, why? Why were they pruned away? How does the brain decide what stays and what goes? And it turns out that the answer is what stays is what's common and what's significant. The most common events, those connections stay. The most significant events, those are the connections that stay. So in that context, while we're discussing patients who have early trauma and subsequent addiction, consider the implications for the connectivity in a person who has been exposed to repetitive, severe trauma at a young age, and how that would affect their development. And keep in mind that as we form these connections with every experience, that the brain circuitry can be thought of as being built from the bottom up. So simple early circuits serve as scaffolds for more complicated behavioral circuits that develop later. So if you have a faulty scaffold or a weak scaffold, it's very difficult to build more complicated circuitry on top of that scaffold later. And adaptations of higher skills are far more difficult if basic skills are not wired or connected correctly. And early childhood trauma certainly interferes with this process. And if the patient before you has had this experience and has not had the ability to develop these more complicated sort of interpersonal executive decision-making skills which developed later, subsequent to the trauma, if it's been maladaptive, that renders that person much more susceptible to addiction. Okay. So I'm going to move on to the next slide here. I was talking before when we were talking about integrative medicine. One of the pillars of integrative medicine is using all of the modalities that are there potentially to help the patient. And I'm lucky enough to work in a place where we have those resources all under one roof to help people. And in many communities, these people are there to help as well. Remember, the way I feel about being an integrative psychiatrist is that it's incumbent upon me to know who I need to involve in this patient's care. Who's going to be on this treatment team? And there are a lot of people on the team. And listen, when I was thinking about, who's on this treatment team, it's no mistake that the patient is the first person listed as part of the treatment team. Because if we don't have the buy-in from the patient, if we don't have the patient committed to addressing all of the work that they need to do to address their early trauma, to address their current state of being, if we don't have them on board, we have no one. And we're going to have a difficult time. Now, central to this as well, I think, is the family, the patient's support system, the closest support system. Many of you may have the same experience that I have, where we here at Sierra Tucson are treating the identified patient. But the story is far more complex than that. So involving the family, educating the family, is a really important part of this treatment team. Now, for me here, too, I think of the referring professional as one of the most important parts of this team as well. One of the things that I like to keep in mind in terms of rendering care at a residential facility is we are one part on this continuum of care. And I remember when I was in the outpatient setting and I would try to refer patients to residential treatment, and I'd say, you have to go here because, listen, you're having this difficulty, you have to go. And they would say, Mike, how long am I going to be there? 30 days. 30 days? I don't have 30 days. That's a crazy amount of time. And then it would be up to me to tell them, listen, 30 days is a blip. 30 days, and I see it here, 30 days is enough time to reset, recalibrate, and get on a different trajectory. And as important as what we do here is the work that has come before and the work that's going to come after. So I really need to be in touch with the person that was treating the patient before they came to me, and I have to be effectuating a really good treatment plan in combination with the person to whom I'm going to refer that patient for the continuing care. And we've even changed the name here at Sierra Tucson. We used to have an aftercare office. And it sounds like a very minor change, but we've called it continuing care now, because we don't want to imply that we're the care and then whatever happens after is sort of aftercare. We are part of this continuum of care that's lifelong for these patients. Now here I also get to work with a team. I get to work with an intake psychiatrist. So as soon as someone gets here, and within the first 24 hours, we get a psychiatric evaluation. So by the time I get to see the patient, they've already had one psychiatric evaluation. There's also a therapist who does a psychosocial when they see them. I really like to see psychometric testing that I get from the psychology department, so I can integrate that into the treatment that I'm going to be rendering. Now we get to a point also where I have to remind people communication is key. So if I'm the primary physician for a patient, there's a lot of people with whom I need to interact, and I need to know that we're on the same page at least, So I have to be in touch with the primary therapist for this patient at every step of the way. I also have to be in touch with the family therapist and hear what they have to say. I also have the ability and the privilege of being able to call in other attending physicians. So if I have a patient with a history of trauma and it's led to, I think, their current addiction, with any one patient, there could be a psychiatrist, an addictionologist. If they're having pain, there might be a physiatrist involved. There's a lot of medical assessment and care going on, and it's up to me to arrange all of that, to organize all that, to make sure that it's all being rendered in an organized and reasonable fashion. I mentioned earlier that we have medical students and residents here, and I remind them that it's a privilege to be learning these skills that they'll use for the rest of their lives to treat patients, and it's also a huge obligation. You know, they're here learning, but they're taking part experientially in these patients' process. So we, as their teachers, have a duty to make them understand the gravity of that, and they become part of the treatment team. Where I am, nursing is another huge part of this team, probably one of the most important parts. Now that I'm thinking about it, you know, sometimes being a doctor is relatively easy. We can breeze in, we write our orders, and we go, and then it's left to the nurses who are there for the next 12 hours in the shift to carry out those orders. They have the most face time with the patients. A lot of their experience depends on the compassion and the quality of the nursing care that they get. You know, I mentioned before earlier, there are many different types of therapy, and depending on the patient, we have to find out what the best therapy is. And again, I don't have to be an expert in it, but I have to know enough to be conversant with the different therapists working with these patients. So, you know, I have to be on top of what the EMDR therapist thinks, what the somatic experience therapist is saying, whether or not it's appropriate to refer a patient for equine therapy. It's important for me to talk to the therapists who are running the groups and seeing how the patient is either thriving or not during their group sessions, and figuring out how they are interacting in the milieu. And then the continuing care that I list there is the last bullet point. You know, we have a continuing care office here that interacts with IOPs and PHPs and whoever we're going to refer the patient to when they're done here with residential, but I think it's also incumbent on the primary therapist here and the psychiatrist to be in touch with those people as well. Because I need to know, how do you plan on carrying out what we've started here? Or what would you like me to do here before they get here, before they get to you? So a lot of this is about communication. Okay, so we'll go to the next slide here. And this slide that I want to show you here is, I was mentioning the field of epigenetics and reasons for hope in terms of the treatment that we get. And you know, we've improved in a lot of different ways. We've improved our diagnostic procedures. We've improved medications that we give. We've improved our neuromodulatory interventions. And it's interesting, sometimes when I'm teaching the students, you know, I'll say, you know, I want you to sit in on this group, or I want you to sit with this therapist. And they'll say, oh, you know, I'm really more interested in the biologic interventions. And I'll say to them, you don't think that psychotherapy is a biologic intervention? Well, no, Dr. Genovese, I'm interested in the medicine or in the TMS and that sort of thing. I want to do things that are going to change biology. And I'll say, you know what, as doctors, it's incumbent upon us. We have to know psychotherapy does make physical changes. Psychotherapy is part of this. There's voluminous data now supporting the notion that experience changes the expression of our DNA. And the field of epigenetics studies changes in gene expression without changing the genetic code. And now we're learning more and more about that. So experience and traumatic experience changes genetic expression. But if it can be changed deleteriously, it can also be changed in a way that can be helped. And what happens in instances like these, in traumatic experiences or in beneficial experiences like psychotherapy, is little chemical groups, methyl groups and acetyl groups attached to the DNA and make some genes more expressive and some less expressive. And so our task now is to study this more and learn more about it and learn how to be more selective in the genes that we turn on that can be helpful and the genes that we turn off that are deleterious. And so what I'm showing you here in this slide, this is a slide showing a microscopic view of a patient with myelodysplastic syndrome, which is a cancer of the bone marrow. And myelodysplastic syndrome used to be a death sentence for patients, because what would happen is they would get, the red blood cells and their white blood cells would replicate out of control, as happens in cancer, and patients would end up dying of bleeding or heart attacks or inability to fight disease. But now we have medications that effectuate epigenetic change. For example, there's a medicine called ecidobon that addresses myelodysplastic syndrome. So it doesn't kill cells in the traditional way that we think about chemotherapy. What it does is it turns on genes that are protective, that tell these cells, hey, listen, you're supposed to be replicating this way. And for some reason in the patients with myelodysplastic syndrome, those genes had been turned off. So if we have been able to figure out how to do it in oncology, we can figure out how to do it in psychiatry as well. So I have lots of hope that as we figure out more and more about the neurobiology, about the etiologies, and the epidemiology of these diseases, we're going to have more and more options. We're going to have more and more people talking about it. We already have more people who are openly coming in for addiction. When I started in the business of psychiatry, when I was in my residency training, addiction was still sort of something that was kept in the closet. It was a private family matter, and that's why it got worse and worse, is that people were not talking about it. Well, there's lots of reasons that we started to talk about it. It could be the burden on the family. It could be the financial burden on the country. It could be the numbers that people are reading about people dying from these diseases. And it's also become more scientifically understood. So as we have more conversation can only be good, because we can't have answers until we have the dialogue. And because I think that's so important, I always list, with every presentation I do, I give my email address, because I love to hear from other people who are dealing with these diseases. Because as I'm here teaching medical students about this, I realize I still have a lot to learn. And collectively as professionals, it's better for all of us if we're working together and we all share our ideas. And we all, we share our successes and our failures. And we share them already through studies, but I think open dialogue among professionals is the greatest thing that we can do for the overall treatment of our patients. Now, there's a lot of data that you can look at, and I put in some of the articles here that I've relied upon in presenting some of the epidemiologic data and some of the neurobiologic data that we've talked about here today. But there's far more out there than what I've listed here. And what I would really encourage people to do is to feel free to reach out if you're interested in one area more than another, and keep the flow of the conversation going. And with that, I think I'll go back to Julia. Thank you.
Thanks, Michael. That was a very informative presentation, and we've already had a number of questions from the audience that have come in. However, we would like to remind you to use the Q&A widget below the slides on your screen to submit a question at any time. Okay, so let's jump in. Let's see. Here's the first question. Is there any way to measure objectively how severe the trauma needs to be to correlate with addiction, or is this based on a subjective experience on severity? And the individual gave an example of sexual abuse. Is there any sort of sexual abuse automatically considered severe?
Yeah, so that's an interesting question, and one of the studies that looked at that, there was a study called the Adverse Childhood Event Study, and it looked at different types of trauma and different levels or severity of trauma, and there were scales that were developed. It was a study that was conducted at Kaiser in California, and it's a really easy study to find. And it correlated some of the severity and the nature. I don't think that there's an objective test that we can use. I don't have a blood test that will give me that information. I find psychometric testing that I get from the psychologist incredibly helpful in that regard. And then the question is, how does that affect management of the patient thereafter? So anyway, I would take a look at that study, and it gives you a whole bunch of information about the correlates there. And then I would also say, yeah, that the psychometric testing can be helpful in that regard, because sometimes we're missing, I think more importantly for me, I might be missing the history of trauma if it's not reported. I'll pick that up during some of the testing that I'll review in anticipation of seeing the patient.
Great, thank you. We've got another question here. When dealing with non-substance related abuse disorders such as gambling, for example, how does it affect the brain in regard to trauma?
It's an interesting, when people talk about process addiction, there's been a lot of questions as to whether or not it's the same sort of developmental processes and the same sort of insults at a young age that'll lead to a process addiction such as gambling addiction or sex addiction as there are to the substance. And there's a lot of data out there suggesting that a lot of the insults that lead to that maldevelopment towards substance addiction are very, very similar to the what leads to the process addiction. If you look at fMRI studies of patients with gambling addiction and you look at areas such as their limbic system or the prefrontal cortices, they look a lot like people who are using cocaine. So it makes a lot of sense. I don't have a specific article in front of me right now that I could say to you, take a look at this one and it will show you that the same sort of experiences can lead to that, the process addiction as to the substance addiction, but it makes intuitive sense, and there is data out there that suggests that.
Great, thank you so much. Here's another question. What can be some healthy ways to get dopamine pathways back on track?
Well, one of the things that I had mentioned earlier was that these connections that are happening in the brain, this is really what people are looking at now. We used to talk about the genome and how we thought everything was genetically based. There was that genome project, and we thought, wow, and now we have all the answers because we know we've mapped out the genome, we know how the chromosomes are formed, and that's going to answer all of our questions. But it turned out it didn't. And it's more of sort of these external factors that affect the way our DNA is expressed. And the way I tell patients to think about it when I talk to them is think about a computer. Think about the hardware and the software. So your DNA is the hardware, and these other factors that lead to the attachment of these methyl groups or these acetyl groups that then affect the connections between brains and sort of restructure these dopamine pathways are the ways that we're going to go about trying to fix them, so to speak. So developmentally, these maladaptive these maladaptive behaviors have resulted from the circuitry gone awry. We can get the circuitry back on track through things like psychotherapy, through mindfulness, through experiential treatment, through medications we're finding out. There's lots of different ways. Through neuromodulatory functions. One of my favorite things is neurofeedback. And if you have a neurofeedback practitioner in your community, you should be reaching out to them, because what they can do is they can have a patient come in and give them a stressful image to look at, and they can see in real time their EEG and the way that they're responding to that. And then they can learn to self-regulate through the process of neurofeedback. So there's lots and lots of different ways to go about that. That's a great question. And I think since there are so many different ways to go about it, trying to figure out which way is the best for your individual patient is really the key question.
Absolutely. Thank you. We have another question here. At what ages are children more vulnerable to trauma? And can you discuss trauma in utero? Kind of a double question there.
So, yeah. So, it's interesting. So the first part of the question, the developmental ages that seem to be really, really critical, between the ages of 3, 5. I mean, clearly it's outside of that window. Trauma can impact people significantly, but there are a lot of connections going on at that time that can be thrown off. Trauma in utero it's a really interesting question because people will take this a step further, and I think that there's a lot of research yet to be done on this. So I'm not going to unequivocally state that we have definitive evidence that this is true, but there's some evidence that trauma that happens to the mother can affect the child because as that child is developing, the signals that are being sent, again, epigenetically, that are regulating the gene expression of the baby in utero can be affected. And there are even some people who hypothesize that that can be passed on generationally. And there are some studies of survivors of the Holocaust that support that. Like I said, I think that there's still a lot of work to be done in that regard, but people are starting to ask those questions a lot, and people are starting to do some really sophisticated studies to try to get answers to those questions. So I like that. I like that people are thinking that way.
Great. We've got a lot of questions, great questions coming in. There are many screening tools to work with children and trauma issues. Can you recommend any?
So that's an interesting. I would, there are some that I know of, and what I'd feel more comfortable doing is getting some from people who specialize in children, because I don't want to practice outside the scope of my expertise. And we treat patients here who are 18 and above. And so there may be things where I used to work with children more frequently. There may be tools that are better than the ones that I used before. But if you want to reach out to me, I can reach out to some of my colleagues who do specialize in work with children and find out what they think the best tools are at this point.
Great. Thank you. We have another question here. When it comes to manifesting childhood trauma, do men and women manifest it differently?
I think that it depends on the nature and the severity of the trauma, and I like to think that everybody expresses everything differently. Certainly there are some gender differences in almost any disease state, but this goes back to one of the predicates that I had mentioned before that I really try to stick to, is that we're looking at the whole patient and the individual patient. So I don't want to say you should be looking for this in women and you should be looking for this in men. I think you should be looking for everything that you possibly can in any given patient, given the totality of their presentation, which includes their gender, but also includes their culture, and it includes the drugs that they've been using, and it includes their family system and what their support is, and a number of different factors. So although that it's probably sort of an unsatisfying answer because it's not that black and white, we have to be sort of comfortable in gray in our field, because we have to be open to taking into account so many different factors.
Absolutely. we have another question here. How does practitioner empathy factor into your understanding and approach when dealing with trauma?
Well, I think that someone just kind of hit the nail on the head with that. I think that that's people need empathy. I think the biggest part of our job is being present and giving empathy for our patients. A lot of these patients that we are trying to help have never felt what it feels like to have unconditional love. They've never felt the ability to express themselves in a way that they feel free and that they're not afraid of. And I think that empathy is as strong a tool as almost anything that I have in my toolbox.
Great, thank you. We have another question here. Do you think in early addiction recovery that there is an appropriate time to start treating the trauma?
Well, that's a really good question because so for example, I will say if someone comes here to Sierra Tucson and they are actively in their addiction and they've never been through treatment before for their addiction, the work that's done in trauma can sometimes be overwhelming to them and they're not ready for it yet. So there have been patients who have come here and that we know that they have an early childhood history of trauma. Tends to be things like incest or physical trauma, but we really need to stabilize the addiction first. So frequently, if we have patients who are coming in, we know they have that history of trauma, we try to work with the addictions first. And sometimes what we'll do is we'll start them out in the addictions program, and then they can transfer into the trauma program thereafter. Now, there are some patients, that being said, who have been through a number of treatments, and they may be active in their addiction, but they've done some work on it before, and they are ready to take on both the difficult work of the trauma while doing the work that's necessary to address their addiction. But I think that if you've never done any work on the addiction, you first have to kind of get the addiction at least under control enough that the patient's able to benefit from the trauma work.
Great, thank you. And we have another question here. Can neuroplastic exercises help the brain to regrow healthy processes that would benefit concurrent disorders?
Yeah, I think, neuroplasticity is another thing. Gosh, if we had hours and hours to talk about it, what an exciting field to look at and things that are effectuating neuroplastic changes. And I think as a medical community, one of our mandates is to figure out how we can enhance neuroplastic changes. And, I've got a ton of studies I'm looking at on my desk about how transcranial magnetic stimulation affects neuroplasticity. I was looking at one the other day about EMDR and how that affects neuroplasticity. And I think that we all have a role to play in that regard, which brings us back to this whole idea of teamwork. And, since the brain isn't fixed the way we thought it was, since there is this ability for the brain to change, particularly in regions like the hippocampus, which are so integral in all of these disease states, since we know we can change that, it's incumbent upon us to figure out ways of optimizing that change and facilitating that change. So that's a really, really great area of research now. It's one of the most exciting areas going on right now.
Great, thank you. There's so many great questions coming in. I'm trying to find one last one here. Let's see. This one says, decision making is the key to neural healing. Do you agree that the spiritual leanings of a patient determine their decision making, and how do you address that within addressing trauma?
Yeah, well, I think spirituality for some people, plays an incredibly important role, and we have to honor that. If we're going to be treating that whole patient, that goes back to one of the basic tenets of integrative medicine: physical, spiritual, and emotional. And for a lot of people, you get into definitions of what is spiritual versus what's religious, and it's different with every person. But yes, I think that to the extent that a person's open to using their spirituality, that if they can use that as a strength in their treatment, that's fantastic, because that's what we need to be looking for is strengths. I think that we spent a lot of time in psychiatry and medicine in general looking at weaknesses, and now we've evolved into an age where we're really looking at strengths and how we can capitalize on those strengths and how we can have the patient see those strengths and use those strengths in their recovery and their ultimate, their health, because that's what we're looking for. We're looking for a balance that's a healthy life. So I think that's a great question to end on.
Great. Thank you so much, Michael. That's all the time we have for questions today. We do have some final instructions regarding CE credit. And again, should you have any issues with this process, please do not reach out to today's sponsor, as they will not be able to assist you in receiving a certificate. CE Learning Systems has approved today's program for 1 continuing education credit. To receive your certificate of completion, you must click the green CE certificate widget, complete the evaluation form, and click Submit. For those watching in a group, as a reminder, please download the group submission guide located in the resources area and follow the instructions provided. For those watching from a mobile device or tablet, you will need to email the help desk to receive a program evaluation and certificate for this program. Please note that CE credit is not available for the archived webinar and only for today's live event. If you have any questions, please click the purple Contact Webinar Help Desk widget at the bottom of the screen. I want to thank Dr. Michael Genovese once again for an excellent presentation today. I would also like to thank our sponsor, Sierra Tucson, for making the program possible. Thank you again to those of you in our audience for participating. We hope you'll join us in the future for another Addiction Professional webinar. This concludes today's presentation. Good afternoon, and welcome to today's program titled Childhood Trauma and Subsequent Addiction. I'm Julia Brown, Associate Editor of Addiction Professional. Today's program is sponsored by Sierra Tucson. Thank you to our sponsor and to those of you in our audience for giving us your time and attention today. Before we get started, we have just a few housekeeping details. Each window on your screen can be moved by clicking